So hello to everyone who's joined our webinar today, and thank you so much for joining this Healthy People webinar. And I'm going to invite, before I get going, the panelists to go ahead and turn on their cameras so our guests can see who you all are. So again, welcome to today's Healthy People 2030 webinar, which is focused on strengthening resilience in children and adolescents. So my name is Carter Blakey, and I'm the Deputy Director of the Office of Disease Prevention and Health Promotion, or ODPHP. And ODPHP is an office within the U.S. Department of Health and Human Services, and we manage the Healthy People Initiative. We're running through a series of slides just to let you know that CEs are available for today's webinar. So I want you to be all aware of that. So the Healthy People webinar series provides an accurate, timely, and accessible data about our Healthy People objectives, all intended to help drive the nation toward better health and well-being. So today's webinar is actually the 6th installment of the Healthy People webinar series. And each year we host quarterly webinars that feature the latest data on select Healthy People 2030 objectives. And we cover important public health topics. So we will focus during this webinar, as we do on others, on community efforts, states, communities, and organizations that are working to achieve the Healthy People 2030 targets through implementation of evidence-based interventions, programs, and policies. So we encourage you to stay informed, to get the latest information on Healthy People in our series by joining our Healthy People listserv. So next slide, please. So today's speakers will cover, as I said, several objectives in Healthy People. We will hear first from Rear Admiral Paul Reed, who is our Director of the Office of Disease Prevention and Health Promotion at HHS. He also serves as one of our Deputy Assistant Secretaries for Health. We'll next hear from David Wong, who is our guru on Healthy People data from the National Center of Health Statistics and leads the NCHS branch on health promotion statistics. Our next speaker will be Lisa Followay, who is the President and Chief Executive Officer of Adaptive Sports Ohio. Lisa will tell us how their program has implemented Healthy People 2030 and really shown the importance of social connectedness in ensuring the health and the mental, not only the physical health, but the mental health and well-being of our youth today, the adolescents today. And by doing that, by ensuring their social connectedness, their mental well-being, physical well-being, really helps kids build resilience so they can face adverse events such as we experienced with COVID-19, which during that period we did learn that kids did suffer in terms of mental wellness. And recently the U.S. Surgeon General did issue a report on social connectedness and the vital importance of that to ensuring the health and well-being of not only our adolescents, but the nation as a whole. We're also fortunate to be joined by some subject matter experts in Healthy People 2030. We have Sarah Kinsman from the Health Resources Services Administration and Jeffrey Whitfield from the Centers for Disease Control and Prevention, and they will join us during our Q&A panel at the end of our formal presentations. So with that, I am going to turn the webinar over to Paul Reed.
All right, thank you, Carter, and thank you to everyone who's joined today's webinar. I'm going to start things off with a brief overview of the Healthy People 2030 objectives featured in our discussion today. So if I could have the next slide, please. So today's webinar is going to explore 3 Healthy People 2030 objectives that relate to resilience in children and adolescents. As a pediatrician, father, and grandfather myself, this is a topic that is very near and dear to me. I'll acknowledge that federal subject matter experts in various focus areas curate these objectives throughout the decade, including following the science behind them, updates on the data, and evidence-based resources associated with each of these objectives. And today's featured objectives include adolescent health, 02, increase the proportion of adolescents who speak privately with a provider at a preventive medical visit. And this objective is managed under the adolescent health topic area work group. Secondly, we have early and middle childhood 01, increase the proportion of children and adolescents who communicate positively with their parents. And this objective is under the early and middle childhood topic area work group. And then we have physical activity 12, increase the proportion of children and adolescents who play sports, which is, as you might anticipate, under the physical activity topic area work group. And these objectives are all Healthy People 2030 core objectives, which means they will be tracked throughout the decade, and progress toward achieving their targets will be updated as data becomes available. Also, as core objectives, they are all measurable, have specific targets sought by the end of the decade. They reflect high priority public health issues and are all associated with evidence-based interventions. They also have valid, reliable, nationally representative data, including baseline data from no earlier than 2015. And as core objectives, they are expected to have at least 3 data points throughout the decade in order to be able to assess any trends that we might see. Okay, next slide, please. Okay, these 3 core objectives all support investment in healthy relationships. Social connection, as we all are aware, is a powerful buffer to stress and a key aspect of overall well-being. And finding people who support and care about you, having open and honest conversations with them about your feelings and experiences, and getting involved in group activities such as team sports, all create healthy and health-promoting opportunities for social connection. In the next few slides, we'll review today's featured Healthy People 2030 objectives and their connection to building resilience in youth. This first objective, Adolescent Health 02, focuses on increasing the proportion of adolescents who speak privately with a provider at a preventive medical visit, as I mentioned. And having time alone with a healthcare provider during an adolescent preventive health visit is a marker of quality care. This type of quality care can help adolescents develop a sense of independence and autonomy while developing their sense of agency as well, and an understanding that it is okay to seek help. Keeping care confidential also encourages adolescents to ask for help early when they have a problem, and makes it less likely that they'll avoid getting care. Research has shown that adolescents without appropriate preventive health care are more likely to engage in frequent substance use and sexual activity and have symptoms of physical and mental health problems. Ensuring youth have opportunities to access a healthcare provider they trust and can talk to is important, particularly when it comes to topics such as mental and sexual health, substance use, and safety from bullying. It can also increase satisfaction with medical care and ongoing access of preventive health services. Equipping youth with health information, resources, and tools is a key step in building resilient youth, and many sectors beyond healthcare can share in this role of improving health literacy. Next slide, please. Positive communication between parents and children includes talking about beliefs, experiences, and feelings. And this type of communication is essential to developing healthy relationships, and it can protect children from health risks as well as help them do better in school. Research shows that children and adolescents who enjoy positive relationship with their peers, parents, and teachers experienced improved academic outcomes. Healthy relationships with peer groups, schools, and parents also play an important role in strengthening overall resilience in youth. Routine positive communications is also critical when parents try to teach children healthy behaviors and protect them from risk. Positive communication and connectedness have been shown to protect children from a variety of health risks, including sexual risk behavior, violence, injury, alcohol, and drug use. A range of interventions have been proven to be effective in enhancing a positive relationship between parents and children, and I encourage you to access the evidence-based resources related to this objective. On the Healthy People 2030 website, you can access resources like the Community Guide's systematic review on person-to-person interventions to improve caregivers' parenting skills. Improving the parenting skills of adolescents caregivers can affect a broad range of teen risk-taking and protective behaviors and help bring about improvements in adolescent health. The next slide, please. Now, the final objective featured in today's webinar is focused on children and adolescent involvements in sports. As reported in the Physical Activity Guidelines for Americans, second edition, the science shows that youth need at least 60 minutes of moderate to vigorous physical activity each day for good health. Yet the vast majority of youth are not moving nearly enough. Participation in sports teams or sports lessons after school or on weekends can help children and adolescents meet these recommendations for physical activity. Also, sports participation can allow children to experience the connection between effort and success, and it enhances their academic, economic, and social prospects. Participation in sports also provides opportunities to engage youth in productive, positive activities outside of school and can help youth build healthy social relationships with their peers. Sports can benefit the mental health of youth as well. Notably, participating in sports is associated with improved psychological and emotional well-being in youth, including youth with disabilities. Unfortunately, children and youth with disabilities experience disparities in participation. Only about 38% of children and youth ages 6 to 17 years with disabilities, broadly defined, report participating on a sports team or taking part in sports lessons during the past 12 months. During our webinar today, we'll hear how Adaptive Sports Ohio is working to advance equitable opportunities for individuals with disabilities to participate in sports. Now, here to provide a picture of where we stand with the data on these three featured objectives is Dr. David Huang from the National Center for Health Statistics. And David, I'll hand the virtual mic over to you at this point.
Great. Thank you very much, Rear Admiral Reed, and thank you all for joining today. Next slide, please. I'm pleased to be here with you today to share data for the 3 Healthy People 2030 objectives, chosen to frame our discussion on strengthening resilience in children and adolescents. As Rear Admiral Reed mentioned in his presentation, the 3 measures I will cover track adolescents who speak privately with a healthcare provider, children and adolescents who communicate positively with their parents, and children and adolescents who play sports. Next slide. The data for all 3 objectives I will discuss today come from the National Survey of Children's Health. This survey was redesigned in 2016. The data collected prior to that year are not comparable with the data I will be presenting today. Another data note I'd like to share is that 2 years of survey data were pooled to provide the rates for all of the objectives I will cover today. Combining multiple years of data allows for more reliable estimates, especially for smaller subpopulations. And although surveys were completed by a parent or knowledgeable adult about their sampled child aged 0 to 17 years, the data presented are for their children, even when shown by parental demographics. Next slide. I will begin by discussing adolescents who speak privately with a healthcare provider. Next slide, please. This objective tracks adolescents aged 12 to 17 years who spoke privately with a healthcare provider, such as a doctor or nurse, at a preventive medical visit during the past 12 months without a parent, relative, or guardian in the room. The 2016-17 baseline for this objective is 38.4%, and the target is 43.3%. Next slide. This slide shows data for adolescents who spoke privately with a healthcare provider in the past year in 2016-17 and in 2020-21 by parents' country of birth and the adolescent's special healthcare needs status. In 2016-17, the overall rate was 38.4%, and in 2020 to 2021, the rate was 39.8%. This slight increase is not statistically significant, so the objective is classified as having shown little or no detectable change toward reaching its target. The differences between each of the remaining pairings displayed in this chart were significant and were highest among adolescents whose parents were born in the US and adolescents with special healthcare needs compared to their counterparts. Next slide. The next two slides show adolescents who spoke privately with a healthcare provider in the past year for selected demographic groups in 2020 to 2021. Throughout this presentation, when discussing race and ethnicity, we'll look at Hispanic ethnicity along with race groups, which exclude persons of Hispanic origin. Among racial ethnic groups, the rate was highest for white adolescents, 45.7%, which was more than twice the lowest rate, 19.9%, for Native Hawaiian or other Pacific Islander adolescents. Next slide. This slide shows that being older, having insurance, and living in a family with a higher income was associated with higher rates among groups by age, insurance status, and family income, respectively. The rates for adolescents aged 16 to 17 years, those with private insurance, and those in families with incomes of 400% or more times the poverty threshold, were at least 50% higher than the lowest rates in their respective groups. Next slide. The next two objectives will cover children and adolescents aged 6 to 17 years. For simplicity, during the remainder of this presentation, I will refer to all individuals in this age group as children. Now I will discuss positive communication between children and parents. Next slide. This objective tracks children aged 6 to 17 years whose parents responded very well when asked if they and their child could share ideas and talk about things that mattered. For simplicity for the rest of the presentation, I will refer to this objective as children and parents who had positive communication. This objective is moving away from its target and is classified as getting worse. Next slide, please. This slide shows the rate of children aged 6 to 17 years whose parents reported they had positive communication during 2016 to 2021. The rate decreased from 68.5% in 2016-2017 to 65.3% in 2018-19 to 62.0% in 2020-2021. Rates also decreased during this time period across all sex and age categories shown. Females and children aged 6 to 11 years had higher or better rates compared to their counterparts. Next slide. The next two slides show positive communication rates for selected demographic groups in 2020-2021. Among racial ethnic groups, rates were highest for American Indian and Alaska Native children and lowest for Asian children. However, rates were generally similar across the racial ethnic groups shown. Next slide. This slide shows data by the special healthcare needs status of the child. Rates were 37% higher for children without special healthcare needs, 66.2%, than for children with special healthcare needs, 48.3%. Next slide. Finally, I will talk about children who play sports. Next slide, please. This objective monitors the rate of children aged 6 to 17 years who participate on a sports team or take sports lessons after school or on weekends. Based on the most recent data, this objective is moving away from its target and is getting worse. Next slide. This slide shows the rate of children who participated on a sports team or took sports lessons between 2016 and 2021. The rate decreased from 58.4% in 2016-17 to 56.1% in 2018-19 and to 50.7% in 2020-2021. Among racial ethnic groups, the decrease was statistically significant between 2016-17 and 2020-2021 for Black, Hispanic, Asian, and white children. In 2020-2021, white children at 58.6% had higher or better rates of participating on sports teams or taking sports lessons compared to their counterparts. Next slide. The next two slides show data for children playing sports by selected demographic groups in 2020-2021. Children who were female, had public insurance, with special healthcare needs, and with obesity were less likely to participate on sports teams or take sports lessons after school compared with their counterparts. Next slide. This slide shows data for children who played sports by their parents' marital status, country of birth, and educational attainment. Children whose parents were married or cohabiting and were born in the US were more likely to participate on sports teams compared to their counterparts. The rate of children playing sports generally increased with higher levels of their parents' educational attainment. The rate for children in households where the most highly educated adult had a 4-year college degree or more was 2.5 times higher than the rate for children in households where the most highly educated adult had not completed high school, 64.8% versus 25.7%. Next slide. We'll end by sharing some key takeaways. Next slide, please. For the total population, there has been little or no detectable change, although rates of adolescents who had private time with a provider differed significantly by population group. Less than 2/3, 62%, of children aged 6 to 17 years had parents who reported that they and their child had positive communication in 2020 to 2021. Finally, the rate of children playing sports or taking sports lessons decreased from 58.4% in 2016-17 to 50.7% in 2020 to 2021. Next slide. Finally, I would like to thank and acknowledge the 3 work groups whose objectives were highlighted today, as well as the NCHS and ODPHP staff listed here for their contribution. I'll now turn it over to the next speaker, Lisa. Thank you very much.
Good afternoon, and thank you, David. It's a privilege to be with you guys this afternoon and present. I'm thrilled to share how Adaptive Sports Ohio is utilizing sport as a tool for human development and creating resilience in youth with disabilities. Sport changes lives. It's a gateway to possibility, and it's the doorstep to human potential. And we believe at Adaptive Sports Ohio that everyone should have a chance to play. Next slide. Adaptive Sports Ohio began in 2009 because of my son, Casey. He's featured in the photograph on the right of the screen. Casey was born with a physical disability and wanted to play sports. However, he needed a way to play that accommodated his ability. We were introduced to adaptive sports when we lived in Indiana briefly, and it changed his life. When we moved back to Ohio, we found that the opportunities were lacking, and we decided that something needed to be done. We started small at Adaptive Sports Ohio, but now we're a statewide organization providing a variety of sports throughout Ohio. Our mission is to remove barriers to ensure that individuals with physical disabilities have a chance to play and to utilize sport to elevate ability and empower futures. Next slide. Before I touch on our programs, it's important to understand we are serving individuals with a primary visual or physical disability. They have a diagnosis that limits their ability to play a traditional sport, although not every participant would utilize a wheelchair every day. They also need the sports adapted either by a piece of equipment or a rule modification. It's imperative to also understand that adaptive sports equipment is extremely costly, ranging from $4,000 per chair to $10,000, depending on the sport. We do not duplicate the great work of Special Olympics because we focus on physical and visual limitations and the adaptations that are needed for those folks to engage in sports. Next slide. We have 3 core programs at Adaptive Sports Ohio. Our community-based sports are open to all ages and physical and visual disability types. They're offered year-round and include recreational and competitive opportunities. Our second program, Everyone Plays Kits, and that's where we send children free kits filled with bags of sports equipment and activity cards. These kits teach kids that they can be active despite living with a physical or visual impairment and provides them the resources to do so. And third, our interscholastic programs. Those are for children that are enrolled in school, and I'm going to touch on those in more depth in just a bit. Our 3 programs align with the social determinants of health, social, and community context because we're providing individuals with disabilities support where they live. We're reducing the societal, environmental, and attitudinal barriers that prevent them from engaging in play. And we're facilitating inclusion and positive relationships through access to play. Next slide. On the screen, you can see statistics from the CDC, specifically regarding the health status of individuals with mobility impairments in Ohio. A few of those that I'd like to highlight, 44% of individuals with mobility impairments are likely to be inactive compared to 25% of the general population. 10% 10% graduate college, while 67% do not work. 57% are obese, and 60% report poor health compared to 9% of the general population in a 14 or more day period. This data is concerning. Next slide. Recognizing that individuals with disabilities struggle significantly with positive health outcomes, the Ohio State Health Improvement Plan identified individuals with disabilities as a priority population and set a goal to improve their health status and increase physical activity by 2023. This is an important step. However, it's critical that individuals with disabilities aren't just offered equal opportunity. They must be offered equitable programs that can achieve actual improvements in their health. Sports cannot cure disability, but we know that if we're able to reach individuals with disabilities at a young age, we can decrease the likelihood of sedentary behavior and increase positive health outcomes over the course of their life. And that's what we're working on here at Adaptive Sports Ohio. Next slide. Nationally, our work aligns with the Healthy People Framework, and we're honored to be recognized as a Healthy People 2030 champion. There are several Healthy People objectives that we align closely with. Through our interscholastic and community-based programs, we're increasing the number of children who have the opportunity to participate on a sports team. Additionally, we're prioritizing the reduction of obesity and increasing aerobic and muscle strengthening activities through our programs. Next slide. Thankfully, there's plenty of research that exists that amplifies what we already know about sports participation. Access to sports builds resilience. It increases academic outcomes of the students who participate. It enhances employability and improves physical, emotional, and social well-being. And all of these things are critical in human development. But unfortunately, when children with disabilities are sidelined, they're missing out on these benefits and they're missing out on them unnecessarily. Next slide. Opportunities for children with physical disabilities to engage in sport are limited in our communities and schools here in Ohio and across the country. As you can see in the chart I've provided, children without disabilities have a disproportionately higher rate of opportunity and participation in Ohio than children with disabilities do. Each school district in Ohio on average offers 25 different traditional sports. Students with disabilities only have an option for 3 formally recognized sports, and that's if they're fortunate enough to know about those opportunities or if their school will offer them. Next slide. While providing community-based programs was important for Adaptive Sports Ohio since the inception, I knew that if we wanted to see greater participation of students with disabilities in sports and systematic change, that we needed to make sure that they had the opportunity to engage in sports at their schools. Our efforts started with my son, Casey, who was the first person in the state to join his school track team using a racing wheelchair. Unfortunately, we did have to fight our athletic association here for access, but fortunately, the law is on our side. The Rehabilitation Act and the IDEA Act both guarantee that students with disabilities have access to extracurricular activities. Usually schools interpret that to mean non-athletic clubs or other roles for a student with a disability, like a photographer, a water boy, or a statistician. But again, at Adaptive Sports Ohio, we're passionate about equitable opportunities. For Casey, that meant the ability to race at the same time as the footed athletes and to score points in seated events. We were able to achieve that with the help of the U.S. Department of Education's Office for Civil Rights. And over time, ultimately, our high school athletic association added track and field events for seated competitors. Next slide. Beyond Casey, as an organization, we've worked to make sure that students with disabilities across the state also have the same opportunity to participate on their track teams. And we've served more than 100 states through, 100 students in the state through our racing chair equipment loan, our coach and student track and field trainings, educating them on what inclusion looks like within the school-based setting. And we provide support at the junior high and high school state championship meets for those students. Next slide. We haven't stopped working on interscholastic inclusion with just track and field. Again, in pursuit of equity, we've worked with school districts to create parallel basketball teams for students with disabilities. And since 2015, we've received support from our state legislature, as well as private foundations. And we've grown from a pilot program with one interscholastic wheelchair basketball team to a full league that should double in size in the next school year. Our basketball season follows a traditional basketball season. The difference would be is that we're open to 1st through 12th graders that are enrolled in the same school district, and that we allow up to 5 non-disabled students to join the team. We do limit their scoring and the number of non-disabled that can play during a game, because we want the focus to always be on students with disabilities. This reverse type of integration strengthens peer relationships, as we've seen, and teaches students without disabilities about empathy and respect. It's also pretty successful in creating a fan base for disabled sports. Next slide. Our grassroots activation of interscholastic wheelchair basketball program is critical. Typically, we're approaching a school district asking them to add the sport as part of their athletic offerings. And as an organization, we're providing them with as much or as little as they need to get started. This can include a fleet of sport wheelchairs, a trailer for storage and transportation, and for up to 3 years, our organization can provide the school with a coach to get that team up and running. We also host a high-quality state championship for wheelchair basketball, which I believe rivals our athletic association's state championship. But to understand a little bit more about this program and the impact, I have a video to share on the next slide.
Playing the game in a chair, at the end of the day, it's not that different. It's still 5 players on each team. It's still the same rules as normal basketball. Both teams are just trying to get the win. This is my 8th season playing wheelchair basketball for the Worcester Generals, and it's just been amazing being able to play as a part of this team for so long. I've loved every second of it. I love having a team of peers from school to talk to, meeting other disabled athletes, to have like a common point of reference. Just, we know where we're both coming from. We've both been through a lot, but we can all talk about sports and bond over sports. I never expected that I would be able to play a competitive interscholastic sport. So having the chance to do that, it's given me something I really enjoy to do, something I get to work towards every day.
I think for those of us who have kids who are born with disabilities, you know, when you first give birth and first have a child, there's just so much uncertainty and worry about what's their future going to look like, and you know, are they going to have a normal life? And for me, wheelchair basketball has been what has given Ryan the normal life that I always dreamed of for him. The chance to be on a high school basketball team with his peers and compete against other schools, you know, that's just the epitome of high school. It gives them the chance to be in shape and be athletic. It really just makes them a normal kid. I think kids with disabilities are a group that are marginalized their entire lives, and they spend their lives feeling like there's so much that they can't do.
So when I was in 6th grade, I heard that there was going to be an assembly for wheelchair basketball. I didn't really know if I wanted to play, and I wasn't completely sure I would enjoy it. After I tried it, I ended up absolutely loving it, and I remember writing in my diary as a little kid saying, today I joined the Jackson wheelchair basketball team, my number's 51, and I was so happy.
The students that are a part of the team, whether they're disabled or not disabled, have again really been able to embrace the perspective of what it's like to have a disability and to still want to be a part of a team, a part of the school community. And that's been really awesome to see as they have learned to work with one another, meet each other where they're at, and really go above and beyond the court, the practice, and spend time even outside of school.
Wheelchair basketball is awesome. I love it. Students that play wheelchair basketball are no longer being seen for their disability. They're being seen as athletes, as winners, as champions, because that's what they are. They come out here and they compete in this sport and doing what they love. Our games are competitive, there's rivals. We get fouls in games, there's 3-point shots. This is a sport we get put on our varsity jacket. We get senior banners on the wall and we get recognition.
If I was talking to an administrator and telling them just why they needed to support like ASPO and the wheelchair basketball teams, I would say it's just to give people like me a chance. Because when I was little, I didn't have a chance, and I really just ruled everything like sporty out as an option. I didn't think I was gonna have any chance to play, but I did because of ASPO.
For all of you that aren't involved with adaptive sports, the time is now to step up for your students, to step up for your school community, and jump in with a full heart.
I'm so happy that you're able to hear from Abby and Ryan. And Ryan was actually our first ever interscholastic wheelchair basketball athlete. And it was pretty exciting to see him in the last 8 years develop and blossom into a young man who's now going on to college and pursuing a 4-year degree. Because we rely on foundation and state support for our programs, it's critical that we have an evaluation method. We use this data that we gain to influence policy and report back on the support that we received. So our staff here at Adaptive Sports Ohio conducts pre, mid, and postseason testing. We also administer a postseason quality of life survey. On the right of the screen are results from 8 members of the Jackson Polar Bears team. The improvements displayed are impressive considering our season is only 4 months long. At the bottom of the screen, you'll see some of the results from our quality of life survey, and that survey captures a parent or guardian's observations of their child's changes in self-efficacy, self-esteem, and social interactions. And as these results demonstrate, children with disabilities are more confident in their abilities and benefit overall from team participation, just as their non-disabled peers do. Next slide. The successes the program has achieved are significant, but we are faced with challenges for implementation nonetheless. And some of those challenges include initial support from school administration for incorporating the team into their programs, available facility space with an already robust athletic program when you have 25 programs and numerous fall and winter sports. Asking for additional facility space to host practices for wheelchair basketball and game space can be challenging. And then on the financial side, it can be significant when you need a team of 12 players and you need a financial investment of $50,000 worth of equipment. That is a barrier that we face. Two others I'd like to mention, depending on the age of the student that is signing up to participate in wheelchair basketball, it can be difficult to convince them that physical activity is a good thing when they've been sedentary for so many years. And then the last thing would be our evidence base. We really strive to have a partner come alongside us and help us do some research on this program and get it to evidence-based research status. Next slide. We found it very helpful in our quest for inclusion to lean on national resources like Healthy People 2030 and the National Youth Sports Strategy Champion Initiative. It's also been extremely important for us to advocate on behalf of individuals with disabilities with our political and governmental leaders, highlighting the CDC data and research from NIDLR and shedding a light on the disparities that exist in this population. While we're not always successful in our grant application, we have found many foundations and communities that have invested in our work, and we're grateful for those partnerships. Next slide. For anyone that has an interest in learning more about the work that we're doing in Ohio, my contact information is available on screen, and we would encourage you guys to follow our work on social media. Again, we've appreciated the opportunity to share how we're working on building resilience in children with disabilities through sports participation. And with that, I'll transition it back to Carter.
Great. Thank you so much. A huge thank you to all of our presentations, presenters, Paul, David, and Lisa. We really learned a lot about important resources and the national data that we can work with to create better programs and policies for our youth. So we now will enter into the moderated Q&A session. So I'd like to invite all of our presenters, as well as Sarah and Jeff, to join us. So please go ahead and turn on your cameras, and we will get the Q&A session going. I have one question that I'm going to start out with for each of our speakers today. So feel free to jump in. I'd like you all to participate. So what types of resources or information, for example, Healthy People 2030 objectives not presented today, or any other resources that you all might have in your programs or agencies, can you share with our participants that would help support those working in the field and contribute to advancing youth resilience?
I'll start us off, Carter.
Great, thank you.
Sure. Well, across the various programs of our office here at the Office of Disease Prevention and Health Promotion, we set priorities for improving the nation's health, provide science-based nutrition and physical activity guidance, and create tools and resources to help people make healthy choices, including children and adolescents. Some of the initiatives that are intended to help favorably influence youth behaviors, health outcomes, and enhanced resilience of youth include the National Youth Sports Strategy, which was briefly mentioned by Lisa, which is a roadmap based on research and best practices for the scientific community that offers actionable ideas for parents, coaches, various types of organizations, communities, and policymakers to advance youth sports participation for all kids and adolescents. Very much aligned with that, the Physical Activity Guidelines, second edition, which is a resource for health professionals and policymakers. That includes recommendations for Americans ages 3 years and up, provides evidence-based advice on how physical activity can help promote health and reduce the risk of chronic disease. And again, aligned, the Dietary Guidelines for Americans, the current iteration of 2020 to 2025, provides advice on what to eat and drink to meet nutrient needs, promote health, and prevent disease. And the current iteration focuses on various age groups across the lifespan and includes new recommendations for infants and toddlers as well as updated recommendations for children and adolescents. Healthy People 2030, as we've discussed, obviously, offers a variety of resources, including many other objectives with their attendant data and evidence-based references that are all related to children and adolescents. And then finally, the Federal Plan for Equitable Long-Term Recovery and Resilience lays out a government-wide approach for federal agencies to take, aligned with the needs of communities to cooperatively strengthen the vital conditions necessary for improving individual and community resilience and well-being. All those places and spaces and other vital conditions that enable such healthy lifestyles. All of this, I encourage you to find on health.gov. You can learn more about any of those initiatives and more. Thanks.
And I'll just
There I go. Go ahead, David.
Sure. I'll just piggyback on Rear Admiral Reed's response and cite the several objectives actually across Healthy People 2030 that can be used to assess resilience in children and adolescents. And they span several different topic areas, including adolescent health, mental health and mental disorders, as well as LGBT health. For example, there's AH1 and 2, which focus on preventive healthcare that addresses the emerging need for confidentiality and progressive independence, and that sets the stage for successful transitions to adult healthcare settings. There's also MHMD2 and 6, which address caring for adolescents' mental health by tracking suicide attempts, as well as those receiving treatment for depression. So just to name a few, there are many others across the initiative. All of these objectives that I mentioned include not just national level data for adolescents as well as their subpopulations, but also, as Rear Admiral Reed mentioned, evidence-based resources for improving the health and well-being of adolescents and reducing premature death.
Great, thanks, David. And then Sarah and Jeff, I'd also like to point out a little management process with Healthy People. So Sarah is our SME, or subject matter expert for Healthy People 2030 on our adolescent health and early and middle childhood topic areas. And then Jeff is our SME for our physical activity work group. So anyway, so Sarah and Jeff, can you share some resources that you all have?
Jeff, I'll start out and then I think we can swing back to physical activity. So hello, everybody. I'm Sarah Kinsman. I'm a pediatrician and adolescent medicine specialist at HRSA. And there's a couple of resources that I think would be very valuable. One stems from the Department of Health and Human Services work that was building a roadmap for behavioral and health integration. And so folks across HHS came together to develop a children and youth resiliency challenge. And this really is to support innovative community-led solutions to advance mental health for children and youth with a focus on resiliency. The idea being that community-led solutions are one of the strongest ways to advance children's mental health. And I encourage everyone to go to challenge.gov and resiliency. And I will also, Carter, may I put that in the chat? Is that something?
Oh, go ahead. No.
Okay, perfect. I'll also include that in the chat. I want to share this because this really is an opportunity for community settings, early childhood settings, primary care providers to think about ways to kind of show us in federal government how to support our kiddos, because so many of you are doing so well. Another resource, so I'll put that in after I finish chatting. Another resource that I think is very helpful is HRSA funds the American Academy of Pediatrics to support the Bright Futures program. And this is one of our preventative services guidelines. As part of the Bright Futures programs, we help providers, families, and communities to foster trauma-informed and strength-based practices that proactively promote the skills needed to respond to adversity in health and promote adaptive coping and future resiliency. And these resources are available for clinicians, nurse practitioners, medical assistants, mental health providers, schools, and families. And so one of the resources that I think is particularly helpful for families and that I have used in my practice Philadelphia is healthychildren.org. And healthychildren.org is supported by the AAP and Bright Futures. And it really gives parents very high quality information in a way that is also very clear and simple. There are sections that address each of the objectives that we've been discussing today. And I strongly support it as a way to get very good information that's very helpful to families. And Jeff, I pass it over to you.
Great, thanks, Sarah. Hi, everyone. I'm Jeff Whitfield with the Physical Activity and Health Branch at the Centers for Disease Control and Prevention here in Atlanta. And I would, as you will imagine, my comments will focus mostly on the sports side of the presentation today. I would direct most people to some resources that we have under our initiative called Active People, Healthy Nation. So Active People, Healthy Nation is our initiative to increase physical activity levels of 27 million Americans by 2027. And included in Active People, Healthy Nation are some strategies that can be employed by people around the country, but also some different information for people in different sectors of society. So a few of the strategies that I would point out would be increasing access to places for physical activity. So things like parks and recreation centers that can be hubs for youth sports, but also shared use agreements. So opening up things like schoolyards for after hours use, which can also support youth sports. We also have school and youth programs, recommendations for school and youth programs that can include comprehensive physical education. So building the skills that create the physical literacy for sports participation. And then I think somewhat tangentially related, we have a lot of recommendations around community design. So how do we design our neighborhoods, for example, to allow people to be to have easier access to places for physical activity, including places for sports participation, and perhaps even walk or ride bicycles there to further increase their physical activity participation. And then there's lots of sectors that we talk about that touch youth sports. So some of those would be recommendations for people working in the parks and recreation and green space areas. But also we have some very clear recommendations for folks working in education, and then of course the sports and fitness arena as well. So all of that's available under Active People, Healthy Nation, and I would encourage you to check it out.
So thank you all for all your additional resources you provided. We have several questions that have come in from the audience. And here's one. It's about how do you build autonomy in adolescents when they're living with their parents who are responsible for providing their health care. Where is the line drawn when it comes to parents being allowed to be informed about a conversation, for example, with a healthcare provider?
I think I'll take that one, Carter. I think it's a great question. I think one of the things that's really important is building autonomy is a process. It doesn't happen at one particular moment. So your kiddo goes to college and all of a sudden they're not able to handle everything on their own, although the health center, as some folks who've had that experience will know, isn't going to talk to a parent anymore. Or an 18-year-old is working and goes to their healthcare provider at their employment, and that they will not speak to a parent anymore. So what is the way that we can build over time, increasing autonomy? And really what you're doing is building confidence that youth can assess whether their provider is trustworthy, whether their provider is focused on their needs, and also starting to be able to know what their health needs are and how to express them. So the question asks, during the time, and this actually goes up to for many youth to the age of 26, parents are supporting many youth's health insurance. And I do think that it's an opportunity for parents and adolescents and young adults to talk about things. It is a time for really to think about when it is that a young person is ready to go solo on something and when they need a parent's support. One of the things that I think is interesting when we talk about time alone is there's this fear that the young person is going to talk to the provider and tell them a whole bunch of things they wouldn't tell their parent. The most common types of things they say is, why do I have stretch marks on the lower part of my, excuse me, everybody, I'm a pediatrician, my butt? You know, those are the kinds of things that people ask. And if there are serious concerns that happen, there were very clear ways and regulation and discussion that happens up front where young people know when we're going to have to talk to a parent or someone else. So I hope that I've shared a little bit about the importance of this process, that it's very rarely ever a time to not connect with a parent, and that the interesting thing about the insurance issue is it gives parents and young people a chance to communicate about their health needs over time. I hope that's helpful.
Sarah, I did put in the chat a link to the CDC's info brief on one-to-one interactions.
Right.
Thank you. Perfect.
And just so everyone knows, Paul is a pediatrician. I'm sure he has lots of thoughts on this, but I'm going to move on to Lisa. So Lisa, can you give some tips and lessons learned from building partnerships and promoting community support, which you've done so successfully?
Absolutely. No, I'm a parent of a child with a disability. And as a parent, it's easy to complain about the things your child doesn't have. And one of the most important things that we've learned at Adaptive Sports Ohio is that when you're approaching a leader or someone that's involved in the government or educational based setting, that you can introduce them and educate them on the problem, but you also need to help them figure out the solution. And sure, over time, they can come up with solutions, but if you can have a conversation that identifies the problem, but also offers a solution and support them through that, it can help things change much more quickly. So that's been important for us here at Adaptive Sports Ohio, and that's a model that we've tried to implement in our partnerships as we work on the ground.
Great, thank you. And then, David, and perhaps Jeff, how much of a decrease in sports participation can be attributed to the pandemic in the years 20 to 21?
Sure. I'll go ahead and start. And as I mentioned, based on the data shown, we actually saw a decrease in sports participation, starting in 2016-17, which is the baseline year, and that decrease continued into 2018-19 and then into 2020-2021. So while that decrease in that final data point does coincide with the onset of the COVID-19 pandemic, the decrease started well before the pandemic, and it's not possible based on these data alone to attribute that decrease to the pandemic. So I'll stop there and defer to Jeff as a subject matter expert on any other insights he might have.
Yeah, I don't really have additional thoughts on that. I think David summed up the situation with that particular data point really well. I think just from a larger, we often get questions about what happened to physical activity during the pandemic, and I just often caution people that it's not a question that we can answer as stated. Physical activity is highly complex. The pandemic was highly complex. It changed over time. Physical activity occurs in different settings, and so those settings were impacted differently. So I think David summed it up well, is that based on the data that we have right now, we can speculate or hypothesize, but we can't directly measure that.
Right. Thank you. Well, we're actually over time. Thank you again to all of our speakers and everyone in the audience for hanging in there a little bit late with us. It was a great webinar. And stay tuned for what we're going to do next.